Hi, my name is Dr. Fakhar Abbas. I'm Chief Resident with Carl Foundation Hospital, which is located in Champaign, Illinois. I'm going to present you a case of lupus-induced pale red cell aplasia. Pale red cell aplasia is caused by immune-mediated death of hematopoietic stem cells, resulting in decreased red blood cell precursors in the bone marrow, as well as decreased circulating RBCs in the peripheral blood. Pure red cell aplasia is caused by many etiologies, but the most common of them is viral etiologies, particularly parvovirus B19, and people with sickle cell disease are more prone to develop it. This atypical presentation has been described in systemic lupus erythematosus as an uncommon but a deadly one. We present you a case of 30-year-old Latino woman with remote history of mixed connective tissue disease, treated with hydroxychloroquine, discontinued 6 months ago by the patient. She presented with severe shortness of breath and was found hyperventilating by co-workers in her office. So 911 was called. En route to the hospital, patient was intubated, secondary to respiratory failure. In the hospital, after stabilization, labs were drawn which showed hemoglobin level of 2.5. Pertinent physical exam findings were trace pedal edema, subconjunctival pallor, tan skin. The quiet test was negative and there was no sign of any external bleeding. So CBC is shown here with hemoglobin of 2.5 and very high MCV of 129.9 with macrocytic hyperchromic features. The WBC count was significantly elevated at 20.8, most likely secondary to stress, and then platelet count of 2.9. Absolute reticulocyte count was undetectable. Elevated anion gap of 34, elevated bilirubin of 3.4, elevated transaminases, elevated alpha phos, elevated D dimers, elevated LDH, and decreased haptoglobin. On coagulation panel, APTT was elevated to 36.9 and INR of 2.6. Fibrinogen level was decreased to 174. Blood pH showed significantly decreased pH of 7.08 and significantly low PaCO2 of 17, secondary to hyperventilation and undetectable bicarb. An extensive workup was done and a provisional diagnosis of acute blood loss anemia was made. Imaging studies were obtained to see any sign of internal bleeding. Chest X-ray showed cardiomegaly, but no bleeding. CT abdominal pelvis again did not show any bleeding, but it showed significant hepatosplenomegaly with mild abdominal pelvic ascites. Echocardiogram showed moderate tricuspid regurgitation and enlargement of the right ventricular cavity. The chest X-ray, which was discussed earlier, is shown here with significant elevation, a significant increase in the size of the heart. Her LDH level were raised, raising the suspicion of acute hemolytic anemia with reduced haptoglobin, but bilirubin levels were not significantly high to explain the degree of drop in the hemoglobin. Her ferritin level was 4180. NMTS level were also very low. So far, we were not able to figure out what's going on. We ended up doing some autoimmune labs, which included ANA, which came back positive to very high titer of 1 ratio 1:80. Double-stranded DNA was slightly elevated as well. And TRNP antibody was significantly elevated. And then antihistone antibody was positive as well. Hematology recommended getting a bone marrow biopsy, which showed scattered through precursors of erythroid cell and a few hypomonolobated macrokaryocyte weakly positive for CD34. A presumptive diagnosis of pale red cell aplasia was made, and viral serology was sent for common viruses associated with pale red cell aplasia, which came back negative. So we went through a chain of differentials, which included acute blood loss anemia, hemolytic anemia, viral infection-induced pale red cell aplasia, and finally lupus-induced pale red cell aplasia. Based on lab studies, we were convinced that lupus-induced pale red cell aplasia is the most likely etiology. In this case, patient received 4 units of PRBC throughout her course in the hospital and later was started on high-dose prednisolone. Patient remained stable and was discharged with 20 milligram prednisolone for 3 weeks and with an outpatient rheumatology appointment. And that sums up our case.